Welcome to Ovarian Cancer, What's New? Presented by Drs. Stephanie Blank and Melissa Frey. This webinar is presented by SHARE, an organization supporting women with breast and ovarian cancers. During this webinar, the doctors will present the latest ovarian cancer research and treatment as reported at the Society for Gynecologic Oncology's annual meeting in 2016. Dr. Blank will present first, followed by Dr. Frey, followed by a question and answer period. Dr. Blank is a gynecologic oncologist at NYU Clinical Cancer Center and an associate professor at NYU School of Medicine. Dr. Frey is a fellow in the Division of Gynecologic Oncology at the NYU School of Medicine.
So basically, the Institute of Medicine, which has now changed its name to the National Academies of Science, Engineering, and Medicine, but it's a really important medical group, commissioned this report, and it came out on March 2nd, and the meeting started about March 18th, so this was right in time. There's actually a whole session about this report. And basically, it's the important thing is that people are giving attention to ovarian cancer, you know, people on a national level, and that's a big deal because it deserves it, and we haven't always gotten it. So this was a congressionally mandated report, and it was sponsored by the CDC, which is a big deal. And they were charged with completing this work. They put together a large group of experts, about 18 people, and they met several times and came up with basically a plan for what research should look like going forward in ovarian cancer. If this is too dry, please feel free to cut me off, okay? So this is basically the state of the science in ovarian cancer research. I don't think it's dry, but it might be dry, okay? And they're going to consider opportunities for advancing cancer research. And I don't mean to go through this so quickly, but there's some slides that are interesting and some are much less so. So this was actually one that they had up there that was somewhat novel in that they looked at sort of studying ovarian cancer in a much bigger way than previously before. Previously, some people might have looked at cells in a dish, and some people might have given people a drug, and there wasn't that much real focus on what the big picture is. And what this is a model that these experts put together in terms of how to think about the disease. And they basically, if you will, the stuff that's over, the stuff that's in the middle is time, and then the long arrows are sort of the different disciplines that are going to be studied. And every single discipline goes over time. But basically what this shows here is that there's, research needs to focus on before anyone gets ovarian cancer, learning how to prevent or detect it. And then there's this whole concept of previvorship, says over there, which is basically a previvor is somebody that has a BRCA or other genetic mutation that predisposes her to ovarian cancer and how she deals with that. And then there's diagnosis and treatment and secondary prevention monitoring for recurrence. So you're treated, it's successful, and then what do you do while you're treated? And that's survivorship. And then we move into long-term survivorship. And the important thing really here is management of recurrent disease, and I would say really management of symptoms would be some of the things that people are looking at. And the whole idea that there was all this focus on survivorship is pretty new, because in some ways it's a little bit softer than other things that they might usually study. There aren't numbers, there are different things that need to be looked at, and it's important that our kind of the people at higher levels are considering people. So survivorship is the person. It's not anything else, it's the person. A couple of things I wanted to mention that were they had some overarching concepts, and one of the important messages was collaboration and disseminating knowledge. Because the other thing is that there's a lot of different silos, meaning there's people here studying this and people here studying this, but everyone needs to communicate, because even though we've all been touched by ovarian cancer, it's not a common disease. So researchers really need to collaborate to make the most of their knowledge. And then it needs to be shared, of course, as well. So this is where you can actually get this report. It's really long. So this is really condensed, but if you're interested, it is there, and it represents a lot of work by the people that did this. So in terms of the biology of ovarian cancer, a really important thing that's come about is that ovarian cancer is not considered one disease anymore. We've always known that it's very different in terms of even the cancer in one person's body is very different from here to here, but there are very many different kinds. And previously, a lot of the time it was defined in terms of how it looked under the microscope, and that is how it's mostly defined now. Now, this color's a little bad, but this big blue segment there is the type of cancer called high-grade serous cancer, and that is probably the most common kind of ovarian cancer, and the kind that probably most people we know have dealt with. And it is the one that we're making a lot of progress in, but it's also the one that needs to be the real focus of our research going forward. That was one point that was made. Now, how do all these ovarian cancers arise? And this is actually part of it that's really pretty interesting. So, have anyone heard about the whole idea of the tube being the source of ovarian cancer? So, serous cancers, which are the important ones that we're talking about, arise from the end of the tube.
Is that fallopian tube?
Yeah, the fallopian tube. I'm sorry. So basically, they rise over here. And basically, the fallopian tube kind of, the pretend Melissa's head is the ovary. It's sort of like this, and the tube I mean, there's little. You can literally see little pieces of it coming down onto the ovary, and that is. So basically, I truly do believe this. Not everybody does believe. You believe it too, don't you? Yeah. So anyway, the tube is the source of the ones that are like we spoke about. The ones that look this is not a very good picture, but these guys look the way a tube would look. Then there are some that come from endometriosis, which is a benign gynecologic condition, and basically it's happens when people. One of the theories is that your menstrual blood goes out the tubes instead of down. And it's an interesting process because it's benign, and yet it can spread almost like it can spread into a lot of different implants. And it's found that some of the other two more common kinds of ovarian cancer actually come from endometriosis. So that's a different thing. And then there's a whole other types that we don't know where they come from. But basically, they all have some origins, and that's the etiology of why they look different. And I spoke a little bit about the idea of things coming from the tubes, and I don't know why there are mice in there necessarily, but okay. So that was one thing. So basically, think of it as a lot of different diseases, and we used to treat everyone the same, but now there's a real move, and you've probably heard of personalized medicine, to treat people differently, and some of it does depend upon how it looks under the microscope, but underneath that is how it what the molecular signature looks like what the proteins look like and such. So that's an exciting thing because we're able to target things a bit better. Now, this was a second sort of recommendation, and this is near and dear to our hearts because we believe in this as well. So, you know, a lot of women who've had ovarian cancer, especially say you had it 10 years ago and you spoke to your doctor and she might have said, well, there's no cancer in your family, don't worry about it. But now we actually know that probably about 30% of women with ovarian cancer have some sort of genetic predisposition to cancer, and it's not only BRCA1 or 2. And if anything I need to be explained, please tell me. But these are basically genes that you inherit from your family, just like your hair color or your eye color, that can make you more at risk to have a cancer. But we're learning almost weekly about other genes that can be important that way. The other thing that we've learned about genetic counseling and ovarian cancer is that any woman with ovarian cancer, even if she has no family history at all, still has that risk. It has not been shown that only the women with family histories that have ovarian cancer are the ones that have the genetic predisposition. Now, one of the reasons why it's so important to know this, there's a couple different reasons. One of them for the survivor herself is that it can have a major impact upon your treatment, like we were talking about before. In certain subtypes, we have medications that work especially well in those people because they are designed to really target the same way that the body didn't work that well and kind of had a typo, if you will, to form cancer. The medication does the same thing, and it can also treat it very well. Now, another important thing about genetic testing is this whole idea of cascade testing. And what that means is if there is a woman who's tested and find out that she has this mutation, she can speak to her daughter and her sister and her other people in her family and basically allow them to get that information, and they can do preventative things. So you can really have a big impact on a lot of people from testing one person. And I mentioned moments ago that there are other genes as well as BRCA1 and 2. And I skipped some of the stuff in the middle, but I did want to speak a little bit about supportive care along the survivorship trajectory, because I was personally really happy to see people up there talking about this. And there is a whole, you know, I'm not only speaking about, you know, last month, but even before that, there's a whole lot now of attention, and Melissa will speak about this momentarily, about attention not only to looking at numbers in terms of how what your goals are for treatment and care, but also looking at what is important to people and how people are living. I mean, if you have some disease and you get a treatment that is terrible, but you live with, but then it treats the disease, but you don't live afterwards, it's not a very successful treatment. So I think a lot of people, we've had a lot of success with ovarian cancer. We have people living longer and better than ever before, but some of them have had lots of treatments along the way, and treatment side effects do add up. And I think it's also just really important to look at different ways to help treat people once they're living beyond ovarian cancer, if you will. And this clearly says this, but most research focuses on treatment rather than how to improve the management of the acute and long-term physical and psychosocial effects of diagnosis and treatment. The fact that a regulatory group said something like this is a big deal. The whole idea, this is black, but the whole, you know, can't see anything, but the whole idea of incorporating the idea of palliative care, which is not what people think of it as, but it's the idea of focusing on symptoms early on in treatment. So that the whole idea of speaking about that, you know, even at the beginning when you start out, is very important. And I think personally they should change the name of palliative care, but that's just my view, because it's not the right term for it. I mentioned dissemination and implementation of knowledge. It's just really important that things be spread. This is by the researchers. And then this is, again, that same picture, but they're talking about a lot of knowledge translation and stakeholders and just a lot of things that need to be done. So basically, this is like a map of everything that needs to be done. And that was about 3 hours of discussion, and then, you know, then the meeting began. So then we were supposed to figure out what was supposed to happen. And these are some of the key messages. Early detection still is not there yet. There are proven preventive strategies, one of which is birth control pills, another of which is removing the tubes and ovaries preventatively. Again, all women with invasive ovarian cancer should receive germline genetic testing. That's a blood test. You go to a genetic counselor at most places, and they talk to you about your family history, tell you what test to get, tell you what it means. That can be really important in terms of a woman with ovarian cancer's treatment and her family, cascade testing. And another big push at the meeting was talking about disparities in care, why some people don't get the treatment that they need. There was a lot of press about this recently, that a lot of women don't get the standard care that's sort of dictated by guidelines that we have, and why that is. And basically, there's different reasons, but if you have ovarian cancer, you go to a place where they see one every 5 years, you're not going to get the same care that you would at a place where they do see a lot. So that needs to be, that kind of information needs to be spread, because people don't always know that. So that was basically the big picture. Now, sorry, any questions about that?
You mentioned that if your mother had ovarian cancer, and I haven't, but actually a test was done, BRCA something, and the doctor said that I did not inherit it from my mother.
Right.
So
the thing is, if your testing was done before 2013, you probably should get retested.
About 3 years ago it was done, my testing was done. She died 25 years ago at the age of 80.
So I suspect you should probably talk to someone and see what you had done, because there still are a lot of other things that might be responsible.
They called it BRCA or something.
Right, and that was previously, prior to 2013, we could test really only for that. Now we have a lot more things we can test for. There was another question, yes?
So you were saying that even if a member of your family didn't have ovarian cancer, you could still.
When I say you, I'm using a woman with ovarian cancer.
Oh.
But yes, it's absolutely true. If you have no family history of ovarian cancer, you still can get ovarian cancer. But when I said you, I'm sorry about that. It was not clear. I meant a woman with ovarian cancer, even who has no family with ovarian cancer still has about a 30% chance of having some gene that is what is responsible for that.
Okay, and then you mention a lot, you use the word treatment often, but I never hear cure used.
We don't use that word that often. I mean, that's a very good point. I would say that when we talk about treatment, like at the beginning,
that's after you already, you mentioned prevented.
Right.
Not even.
So once you have a diagnosis of ovarian cancer, in some situations it's surgically cured, most of the time not. Sometimes you have surgery and then you need treatment on top of that. And that treatment is oftentimes gives you a complete response. That means there's no evidence of disease. Can we use the word cure? Cure implies so much in the future.
If you're superstitious, you can't.
Right, I know. But it also implies a lot in the future. So, when we say our cleanest term for somebody is no evidence of disease, and that means there's nothing that you can find right now that shows any disease. But does that mean they're going to be that way in 10 years? I can't really say that. So I don't think we use that word much, but it doesn't mean that there aren't people that do get treated and never have their disease come back, because we've all seen that.
Dr. Blank, just so she knows, there are some people here.
Oh, yes, please,
who
yes.
are long-term survivors who have not recurred. So just so that you know that there are, we may not use the word cure because of superstition, but there are some of us.
Okay.
Okay.
I didn't quite, I know you mentioned something about preventative, but I didn't hear too well about what could prevent it.
There's a couple ways to prevent ovarian cancer. I mean, things that we remove the we remove the tubes and ovaries of women that might be at increased risk for ovarian cancer. If a woman is having a hysterectomy for another reason and chooses to have her ovaries out at the same time, that will prevent ovarian cancer. There is some belief now that removing just the tubes, so instead of tying a woman's tubes when she's done having kids, actually removing her tubes, that may prevent ovarian cancer. We don't know that all the way as yet, but that's sort of an interesting thing to think about that is getting a lot of attention. And the other thing is birth control pills actually reduce the risk by half when they're taken when people are young. You don't take them when you're much older, but if you take them when you're young, that will decrease your risk by 50%. So, when I see a young woman who maybe her mom had ovarian cancer or something like that, and she wants to know what she could do, I will frequently put her on a birth control pill, because that's better than anything else that I can do right now. So those are the main ways. There are other things that are preventative, like having more kids is better, but people don't do those things to prevent ovarian cancer.
I was diagnosed in the beginning. The doctor said I had peritoneal cancer, but of course it's treated like ovarian cancer.
Right.
And they still aren't sure. I had a hysterectomy too. But also, my father had myeloma. That was the only cancer in my family when they asked me. And I got ovarian. Well, cancer.
Right.
Gynecologic
cancer that's difficult to understand.
Yeah.
Yes.
So that has nothing to do with a woman.
The myeloma or primary peritoneal?
Yeah, his kind of cancer had nothing to do with mine.
Probably not. Probably not. That's probably something different.
Although colon cancer in a male can
Yes.
be related.
Oh, really?
Yeah, breast cancer in a man, they do get that. Pancreatic cancer. There are men's cancers that can be related to women's ovarian, women's cancers as well.
Want me to get the next
Yes.
slide up?
So I wanted to speak. I don't have a sense of time. Do you have a sense of time?
6:35.
Okay, so I have to not speak for too long. But I'm going to speak about one of the presentations at the meeting that got a lot of attention was, if it was this presentation that I have right here. This was a presentation of a large study that was done across the country. I don't believe it was done in any other countries. It was just done in this country, but lots and lots of sites, looking at intraperitoneal chemotherapy for ovarian cancer, which this is of interest really at the beginning. This is not treatment for recurrent cancer, but this is upfront treatment. And the concept here is that some of the chemotherapy is given straight into the belly, and there's been some exciting studies that have shown really longer term survival with that than we ever saw before. Now, earlier this year, there was a big study that came out that said, people aren't using intraperitoneal chemotherapy. Why is that? And there are definitely people within our field that some people believe in it and some people don't. One of the big study that sort of led to the big, excitement about intraperitoneal chemotherapy was years ago, and basically, women would get some of their chemotherapy straight in their belly at these very high doses, and it would make them very, very sick. And only about 40% of the people that started getting that treatment could actually finish the treatment. But nonetheless, it showed that people lived longer. Even if you got one of those, usually, you do 6 courses of chemotherapy at the beginning usually. Even if women got only one of those, they still had some benefit. But nobody could finish it. And when I was in training, we put people on the trial that I'm talking about, and we prayed for them not to get that arm because they would be so sick, so sick, and we would have to put them on fluids at home, and they were really suffering. But then, when they looked at the data that came really far out, people were really living longer. So that's something else Melissa's going to touch on, like dealing with side effects and what your expectations are for that treatment. So this has been debated for a long time, and so our large cooperative group put together a trial. The other side of this is that there was a very exciting study that came out of Japan looking at something called dose-dense therapy, which is instead of getting your chemotherapy every 3 weeks, getting it every week, and this is all at the beginning. But they had amazing survivor results. I mean, one of the median survivals for that, which is like half the people live longer, half will live later, was 10 years, which you never see in any kind of cancer journal. You never see that. So that's a very long number. And then the question, people in this country had some issues accepting it because there was there must be something different. Does this really apply to our population as well? We didn't know. So we had the exciting thing about the intraperitoneal chemotherapy, some of it straight into the belly. We had the interesting thing about the chemotherapy being given every week, that might make people live longer. And then we had the idea that maybe you could use the chemotherapy into the belly, but you could use a less toxic drug. So those were kind of the 3 ideas, and those 3 things were compared. And the other thing that happened in this study is that every single arm, this was designed in a time when everyone was very excited about this drug called bevacizumab or Avastin, which you've all heard of probably, but it was in every arm, which had never been done with the study before, which I'll speak in a little bit, made it a little bit harder to interpret these results. So everybody was very excited about this study because we all thought, what did you think, Melissa? I thought arm 2. I thought the less toxic intraperitoneal arm was going to be the winner. We thought that was going to be a great thing because then people could take this difficult treatment and they would get the benefits without sort of suffering as much. And everyone had their own views. A lot of people thought the top one, which is all through the vein which is the dose-dense one, would be the thing. So we were waiting for this. And this was presented at our meeting, and that's what we're having. One thing about the more toxic of the 2 intraperitoneal regimens is it was still made less toxic than it had been originally in the original trial because it was really thought to be too much for people. So when we got the results of this trial, there was really no difference between any of these arms. And this is not looking at how long people lived. This is looking at how long people went from finishing their treatment till any disease coming back. And the reason why that part at the bottom is circled in red is because one thing about, this is very technical, but one thing about this study that made it harder to interpret is that people were getting CT scans all of the time. So if you get CT scans all the time, you're going to find things earlier than if you do not get CT scans all the time. And it doesn't necessarily, it just means you're going to probably be treated sooner. It doesn't necessarily mean you're going to do better. So they were looking harder for things to come back. And they weren't so excited about these results either, because see, whenever 2 lines are on top of each other, or 3 lines, it means that the study's negative. Some people say you should be able to put your thumb in between, but same thing. So basically, these are the numbers that we had, and this is the study that I was talking about. These are numbers of median survival. this is the numbers that we were all really excited about, this 60. And then we looked at these numbers for this trial, and they were so much less, and we didn't know why that is. I mean, one reason why this is because this was like a really select group of women with ovarian cancer. But the other thing, maybe it's on this next slide, is that, you know, what happened here. And I think a lot of people think that the Avastin or the bevacizumab might have messed up the analysis. A lot of people think that maybe because they were looking so carefully, it messed up the analysis. A lot of people think also maybe because you decreased that dose of chemotherapy to be less toxic, that might have messed up the analysis. So everybody at this session was basically stunned after this. And one of your share members was here, Annie, and we saw her, and she just looked like, you know, we all felt this way, like, how can you possibly say this? And it became very interesting because a lot of people wanted to know, what are you going to do with this? Because when things are presented at a meeting, they're not all the way done yet. So, you know, you follow these things out longer, things change. And basically, you know, is that when something is done, it gets published in a paper and stuff like that. So, you know, do you change your practice based on this? Because if intraperitoneal chemotherapy is not better, why subject women to it? And, you know, a lot of people we've had a lot of discussions about what to do at this point. And I'm sorry, because I'm sure nobody right now here is making the decision about intraperitoneal chemotherapy or not. But it's an interesting point. I think at this point in time, we're continuing what we're doing, meaning we believe in I'm speaking for you again. We believe in intraperitoneal chemotherapy, and we are still offering it for people. It's not right for everybody, but at this point, we still have to wait on these data. But this was one of the bigger this is probably the biggest controversial topic at this meeting. Some of the discussion, I think you were mentioning it. What was the discussion that you heard, Andrea?
Well, that maybe some institutions will back away from it.
Yes, some people are backing away from it. Not everybody is doing it. It was very big here in New York. In Texas, it's not a big thing. I mean, I will say, you know, totally anecdotally, people are living longer. I don't think that people are not living longer now. So I don't know. It's very hard to look at numbers like that and believe them. Yes.
I saw some criticism of the fact that bevacizumab was used.
Yes.
And that really changed the study from the original study.
Yes.
You know,
yeah, it's unfortunate.
But
yeah.
One would think that if bevacizumab is working so well, it would only increase the survival time. So
it's hard, but part of the issue is that was the assumption, but it had never been proven. And there was another study. There was another study that looked at people with more advanced disease, and they had the option of adding bevacizumab, and the people in whom it did not work were the people that were getting that Taxol every week. So there could be some negative interaction there. It might work against it.
Why did they combine all of these things? It's, you know, I mean, it doesn't seem to be a very clean study with having so many confounding
You're absolutely
parts.
Correct. You're absolutely correct. And that's what I thought you were going to say. So I can't remember what somebody said something like, oh yeah, that's a good question, or something that was a little bit unsatisfying. You know,
Doctor, excuse me. Doctor, was the chemo drug Doxil mentioned on that chart?
No, the Doxil was not mentioned on this chart.
Why not?
Because this is the drugs that are used at the very beginning. So
it's a new drug? Doxil's the new drug?
It's not new, but it's used a bit more often when disease comes back, not right at the beginning. But there are very interesting studies with Doxil, and we do use that a lot.
Did they talk about the immune system fighting the cancer?
Yes, there was a lot of talk about immunotherapies, and I think those are all right now available on a trial, and I think right now we are trying to move ovarian cancer into one of the diseases that is considered to be it is a very immune cancer. We know that. If you think about melanoma, the whole survivorship and everything about melanoma has changed with immunotherapies, because there are different ways you can use your immune system to fight the cancer, and that's something. It's still really, we didn't have anything that I would say you could take from here and say this is the great white hope in terms of immunotherapy, but potentially from ASCO, I mean, I'm sort of saying this, I would say that something big like that might be presented at the big conference in June. I do think that that is sort of where people are looking for things. An exciting thing about immunotherapy is it keeps working even when you're not taking it. So it does its thing, and then you can do well. Yes?
Are there any other ongoing trials looking at IP versus IV?
This was the big trial. So part of the other reason why there was a little bit of winds out of people's sails is it's kind of hard to imagine that there's going to be a big investment of so many people and so much into doing another one. So there's nothing else right now, to my knowledge, that's randomized. Like, this is randomized and a big scale study. So we don't have something right now.
Want me to get the next one up?
Yeah, maybe would you like to speak a little bit?
Sure.
Or this is going to be better. Do you want to sit here?
Sure, which one do you want me to start with?
Whichever one you like. So these two studies that Melissa's going to present. Which one?
Let's do the genetics one first.
Yeah, that sounds good, because then we'll end with the other one.
This one, yeah.
This speaks to the fact of what I was saying to you before about how people might have been, about testing. There are now these panels where you can get a lot more information. And Melissa, go ahead.
Sure. So in June 2013, the Supreme Court ruled in a unanimous decision against single gene patent rights. And what that meant was previously anyone who got genetic testing had to get it through one company called Myriad. And sort of the day that the Supreme Court decided that other companies could offer this testing, suddenly there were multiple companies offering BRCA testing, but also something called panels. What a panel means is you can test for many genes using one blood test. And that's really because we have new technology that allows you to sequence from multiple genes, but also it's a way to do it quickly in a cost-effective manner. And then also the other important point was, with new research, we know that BRCA1 and 2 are not the only genes that predispose women to ovarian cancer. There's another syndrome called Lynch syndrome, and then there's some other genes that have just been sort of published and discovered over the last couple months and over the last year that we also think contribute to ovarian cancer. And so many women now, when you get tested, are getting panel testing, and many women who had BRCA testing in the past that was negative can go back to a genetic counselor and ask to get one of these bigger panels where you're testing for really up to 40 or 50 genes. One issue with testing these genes is if you're going to test 20, 30, 40 genes, you might find a mutation where we can tell you, this is your risk of ovarian cancer, we recommend getting your ovaries removed, or we recommend this is the best treatment for you. But there are also genes that we know are abnormal, but we don't know really what that means or what you should do. And that's called a non-actionable mutation. And that can be very confusing for women and their family members because it's just sort of negative information, but without a recommendation from a doctor. So sort of our goal was to look at all of the patients at NYU who had genetic testing. So this was not just breast and ovarian cancer, but this was any cancer, because we sort of wanted to figure out if they had panels, how many of them were getting mutations and how many of the mutations were actually useful. So we looked at patients really starting June 2013 when there was that Supreme Court ruling through January 2015, and we looked over all of their sort of mutations to see what the results were and what we could make from these results. We actually were able to find 454 total patients. One interesting thing about our NYU patient population is we had a lot of Ashkenazi Jewish patients. So 30% of our patients were Ashkenazi Jewish. And this is interesting because we know there's a lot of BRCA in Ashkenazi Jewish patients and a lot of ovarian cancer, and we'll get back to that in a moment. So among these 454 patients, we actually found mutations in 12% of patients, and we found something called VUS. Those are variants of uncertain significance in 43% of patients. And so those are really results that we think we have no idea what they mean. We think they probably mean nothing, but when you look over your report, you're going to see that there is this result that might be abnormal, might not, but we really know nothing about it. And so if a woman is deciding to get a panel, she has to know that, she almost has a 50% chance of having some result that's confusing and not going to help us with her treatment or with anything. And so that's important because it can cause patient anxiety and physician anxiety, and it might make a patient, ask for their ovaries out when we really have no evidence that they should come out. So we also then looked at, women who actually have mutations. So not just these sort of variants that we don't understand, but women who have mutations, sort of about 80% of them, these mutations, we have guidelines as to tell women what to do with their mutations, and about 20% we have no guidelines. So we know there's a problem, but we don't know what it's going to cause or what to do with it. we tried to see, if patients are younger or older, or if they have a personal history of cancer, a family history of cancer, will that help determine who this testing works better in? We actually found that it didn't matter your age, what kind of cancer you had, what your family history was. In general, 80% of people will have a useful result and 20% won't. The thing that we found that was interesting is we looked at our Ashkenazi Jewish patients, and we actually found that if you do this testing and you find a mutation in a woman who's Ashkenazi Jewish, you get a mutation, about 95% of the mutations are actually going to give us useful information, which we thought was exciting. And so if you look here, there are two pie charts on the right here on the left side. Those are our Ashkenazi Jewish patients, and you can see that almost the whole pie is red. And what that means is the genes we find in these Ashkenazi Jewish women are genes where we know they cause cancers, and we can give you a recommendation. And if you look at non-Ashkenazi Jewish patients, there's more blue, and the blue are genes that we kind of don't know what to do with. Another interesting thing is that if we in just a general group of Ashkenazi Jewish women, you expect about 2.5% would have a BRCA mutation. But in our group, we found less than 2%, like 1.5% had a BRCA mutation. And we thought that was strange. And so we looked back and we found that a lot of Ashkenazi Jewish women were actually just getting BRCA tested. They weren't getting these bigger panels. And that's probably because some of them might have had a family history of a BRCA mutation, or because a lot of physicians and Medicare actually thinks that Ashkenazi Jewish women should just get BRCA testing first. But what we found is that these Ashkenazi Jewish women actually have mutations in many other genes. So just because they have a higher rate of BRCA mutations doesn't mean they also don't have a higher rate of other mutations. And sort of the last thing that we found is, even while collecting data for this, while we were doing this study, so over the course of 6 months, new genes became available that we found were associated with ovarian cancer. So you really, if you're going to get testing, the patient who gets the testing really has to stay on top of their results, because you might get a result that we tell you is meaningless that can change. And so sometimes that just involves calling the genetic counselor who did your testing and checking in once every 6 months or once a year, because this is a really dynamic area of study that's changing monthly. And so I think sort of our main conclusions were, if you do this panel testing, you're going to find many mutations. So 12% of our patients, that's a good number. You will get a lot of these meaningless results that might just be scary without giving you any important information, and that can be up to 40 to 50%. And so you have to be aware of that before you agree to have this testing. And then finally, women with who are Ashkenazi Jewish should not, we believe, just get BRCA testing, because they're at risk for many other mutations that we'll miss if we just do the BRCA testing alone. Does anyone have any questions about that presentation?
This does not apply if you're not Jewish, or that doesn't
Well,
apply?
no, we still think panel testing is important, because if you look at, this pie chart, this is non-Ashkenazi Jewish, so this is all other patients. So we still see mutations in many, many, many genes, but we just think it's especially important in Ashkenazi Jewish women, because those are the women who are still only being offered BRCA testing. So we kind of just want to let them know that they're at risk for other genes. But I think what we found is that all patients and all women would benefit from having a panel versus just looking for 1 or 2 genes. And the cost is the same, and the time is the same. And I think it's just, we have to inform physicians and have more genetic counselors involved.
And Dr. Frey, isn't it true that BRCA 1 and 2 even, which is most commonly associated with Ashkenazi women, is found in many, many other ethnic groups?
Yeah, exactly. It goes the other way as well. So many, we see many non-Ashkenazi Jewish patients with BRCA mutations who you would never expect them in.
Would you advise retesting in somebody who had, let's say, a known founder mutation at this point?
So, we actually do believe in retesting for patients who just had single gene testing. And sometimes if you have a family history that doesn't go along with just a BRCA mutation, even if you have that mutation, we are offering women to get retested. And we are finding some women who have multiple mutations. And so we do think that it should be an option for women. And it is, insurance so far is paying for it for many of our patients. And so it's something to consider.
You would want to think a little bit about how it would change what you're going to do. Because if you've already done risk-reducing surgery, it depends
Right.
too. You want to think how you're going to use it. And another point is that this just speaks to the fact that we don't believe that you should, get to pee on a stick and get all your genes and mutations. This really needs to be done under the guidance of a genetic counselor, because the results are so confusing.
This is for pre.
Or
you can find out before, what, or you already.
It's either. It could be at any time.
Okay. So my question, what about, is this BRCA, is this the same as the CA-125?
No.
That's different.
Yeah.
And then the transvaginal ultrasound, those I know are two that you could get tested for to see if you have ovarian cancer, correct? Okay.
They're not great screening tools. I mean, if you're at increased risk, we do them sometimes, but there are a lot of problems with screening tests in general.
So you recommend, well, you said the panel testing is kind of, I don't know.
The panel testing can let you know if you want to do if you want to go for that kind of screening, because if you test a whole bunch of women in the general population with ultrasounds and CA-125s, you're going to miss a lot of people that have problems, or you're going to find a lot of problems you don't want to have. You don't want to find, because they just lead problems in an ultrasound can lead to surgery. So it's a kind of a big deal. It's a lot of people think that it would just be a great thing if we all checked CA-125 and ultrasounds in every woman, but there's a lot of problems with that as well.
Also, just so you know, I'm going to plug this program we have upcoming, and I'll give this to you after. We have an upcoming program on understanding CA-125. I'll give it to you after.
And did they mention anything about ovarian cysts, and if they stay on the ovary for a very long time, never go away, or did they mention anything about cysts?
In general, I think that we're learning that there are some that are never going to become a problem, some that are just like a balloon. But I think it's there's a lot of different things. It's not just a cyst or not a cyst. It's like the architecture of it. There's a lot of things to look at. But there are many cysts that will never not be, never turn to something bad. But don't take that from me. Like, talk with someone else about it.
Excuse me. In terms of the finding of mutations, is there a statistic on the potential incidence of a meaningful cancer based on one or more genetic mutation or combinations of genetic mutations?
So I think for some genes we know, like if someone has a BRCA1 or BRCA2 mutation, we know their specific percentages of, in a woman's lifetime what her risk of developing ovarian cancer are. But the problem with panel testing is you might be found to have a mutation in a gene that has only recently been discovered, and so we don't know what the sort of quantity of risk is with that gene. There's a lot of uncertainty, which is why we say that before you have the testing, we really want you to meet with a genetic counselor so you're aware of what the results might bring.
Do you want me to pull up the
sure.
next one?
Can we do the next one?
I was tested with the CA-125, and the numbers were low, and I had a recurrence of cancer. And the doctor told me that it's only like 10% of the women can have a low rating and get cancer again. How lucky I was. It was like 28 and had come back.
All right, so this is kind of shifting directions a little bit, but I think
I'm sorry, one more question. Genetic counting. No one ever told me to get that. It's very important.
I think it's something that's really gotten a lot more attention in the last couple of years. It's not something that we used to do as routinely, especially if you didn't have a strong family history. Yeah. But now we're recommending it to every single patient we see with ovarian cancer.
And it's now covered too. So that's an important.
It's not covered.
No, it is.
It is.
Oh, it used to be a lot harder to get coverage. It is covered.
And how do we find out about it? Just go wherever, in location to where we live, that there are genetic counsel?
Usually associated with academic places, probably where your doctor is. They probably have a genetic counselor that you would want to. I'm not certain, but that's generally what they do. I mean, in our place, they don't charge, so it's like part of your, seeing a nutritionist, seeing a genetic counselor. It's part of your care, but you would speak to a genetic counselor.
If you were negative I was tested probably in 08, 09, somewhere around there, and it was no BRCA1, BRCA2, nothing. It still would be to my advantage to get tested again?
You could consider it. I think we don't know yet. There's no firm recommendation, but we have offered it, and we now know there are other genes that might cause this.
Okay. Because I had breast cancer 20 and a half years ago.
I just want to say, if you're on Medicare, if you have Medicare coverage, they are paying for this, the panel testing, if you are at risk. Costs nothing.
All right, so now I'll do sort of the other talk I gave. So as Dr. Blank already mentioned, ovarian cancer is kind of unique in that women have very long survivals and they often have multiple treatment regimens and sort of a long cancer continuum. And in the past, there was really a focus on overall survival. So how long do you live from the moment of diagnosis? But recently, there's been a lot more attention to quality of life. And there was an FDA workshop with SGO and then also sponsored by some other groups like ASCO and AACR, really to talk about what are meaningful endpoints when you design clinical trials. Should we be focusing just on how many months the patient lives, or should we look at other things like some of which are sort of quality of life and patient-reported outcomes? And Annie Ellis, who we worked with on this project, presented at this meeting in September in front of the FDA, and she used two ovarian cancer survivor questionnaire results. One of them was a big study done with ACNA, and the other was a study actually that we did 2 years ago with SHARE, where we did a focus group of women, and the point of that was just to discuss what's important to women, what do women prioritize, and sort of along their treatment course. And I think both of these studies showed that there's sort of a new paradigm in ovarian cancer where women and their physicians work together in a shared decision-making model, and that you really have to incorporate a woman's goals for her care when making decisions on treatment and look at both the efficacy of the treatment but also quality of life. And so the objective of this study was really to use a questionnaire to determine ovarian cancer survivors, sort of how will they accept, what's their acceptance of treatment side effects, and how does that change over their disease course. And so Annie developed this 30-question questionnaire, and it was distributed online this past summer in August 2015. It was identified by self-identified ovarian cancer survivors, and it was distributed by social media and other survivor networks. And she was able to get 328 women to participate. Here you can see some of the demographics, like the age, the race, ethnicity. The majority of women were ovarian cancer, but we did have some fallopian tube and primary peritoneal. The majority of women had stage 3 disease, but there were women with all stages. Then we just wanted to know sort of how long had patients had their diagnosis for. So you can see, most patients had the diagnosis for like at least 1 to 4 years, and there were women with both recurrent disease and who had never recurred, and there were women who were undergoing treatment at the time of the survey, and some women who were not. And so when we asked everyone sort of what is your treatment goal, overall survival was the most common, and that's what the other surveys have found also, is that women want time. They want to know that they're going to have overall survival. But that a very close second is quality of life, and so that means that, although you want months and years, you also want to feel well while you're on treatment. We then asked sort of a related question, but what's most meaningful to you? And again, overall survival was the most common. That's that blue area right there. But then again, a close second was ability to engage in daily activities. So that's what we think of as more quality of life measures. And then many women wanted to minimize side effects from treatment and minimize side effects from disease. We then asked, so if you're presenting a woman with a treatment, sort of what do you expect? And we found that about a third of 35 patients wanted cure, about 50 patients just wanted remission, and then 16% of patients we asked wanted to have stable disease. That was what they were expecting. We broke this question down into patients who never recurred and patients who had recurred at least once. And it's not surprising that patients who had never had a recurrence before, many more of them want a cure. And then once patients have at least one recurrence, they're sort of more focused on remission and stable disease and less focused on cure. The sort of meat of this project that was the most interesting was looking at what side effects from treatment were survivors willing to tolerate, and based on each treatment goal. And so we looked, sort of, you can see all of the side effects that we asked about are on the y-axis, so alopecia, fatigue, GI complaints, headache, sexual side effects, and then you can see the percentage of women who said they would accept these side effects for a cure. And you could see that women were really willing to accept some pretty toxic side effects if the goal was cure. And even, more than 20% of women are going to accept feeling short of breath, having bowel obstruction when the goal of treatment is a cure. this is the same data presented sort of in the reverse direction, but then we can compare the blue bars, so that's if your goal is cure, to the red bars, so that's if your goal is remission. So you can see that sort of as a woman's goals change from wanting a cure to hoping for remission, it seems like women become a little less tolerant of all these side effects, and then that number is going to drop even more. The green bars are when the goal of treatment is stable disease. So as the goal changes to stable disease, it seems like ovarian cancer survivors really are focusing more on quality of life issues. One thing we were sort of surprised to find is that if we looked at women who had already recurred, there was this group of patients who wanted a cure after having recurrence, and these women actually were still very willing to tolerate a lot of terrible side effects. And I think our assumption sometimes is that once a woman has recurred, we really should maximize quality of life and not talk as much about, cure. But I think this was important for us to realize that, every patient is different, and some patients are willing to tolerate side effects no matter how many times they've recurred. And that sort of just reminded us that it's very important to check in with the patient because every patient is different in which side effects they prioritize. And these were just some quotes that we had from women who participated, and you can see that, when the goal was cure, people would say, they would accept anything, even things that have a high chance of killing them because they just want a cure. But then as you move to remission and stable disease, it becomes, side effects become more important. And sort of our conclusions were that, we have to realize as physicians that a woman's sort of tolerance of side effects changes over time, and that we have to, check in with our patients. And we're using sort of information we got from this study to create a survivor's decision tool, with the idea being that before you choose a treatment, you can sort of check in with yourself and think, what toxicities am I willing to tolerate? Is hair loss an absolute no? Is neuropathy an absolute no? And then that will help you kind of discuss with your physician what treatments are acceptable and what treatments aren't acceptable.
Cure, I understand. Remission is just, it has ceased for a period of time, temporarily.
Right.
And stable disease.
It's not growing, it's just
there. It's there, but it's not
getting worse.
Getting worse, okay.